Yes, good morning, everybody. And I want to start by just thanking you for the invitation to speak today. I initially thought I wouldn't develop any slides for this presentation and just talk about some points. But then I sat through all day yesterday, and I decided that probably I should include some slides. And I think that I probably was invited here because I've done a lot of work on the new formulations for buprenorphine that have recently come through the FDA, and I will be happy to talk about those, but I think that there's some other things that probably are more important to talk about with respect to how they fit in. Okay, so this would be my plea to this committee, is that there's a tremendous amount of discussion underway. There's a lot of money that's coming in from the federal government to try and stem this tide of death. And for that, I am really grateful. But I feel like we spend a lot of time talking, and we spend a lot of time talking amongst ourselves. And what we all know is not what the rest of the community knows. And if we don't bridge that gap sooner, this is not going to stop. And there was a recent study that looked at a number of different types of interventions, many of which are underway now, and modeled those that would actually lead to the greatest decrease in overdose deaths. And they estimated that without further intervention in the next 5 years, another 235,000 people would die, and in the next 10 years, over another 500,000 people would die. So the time to do something is really right now. We don't have time to wait any longer. What they concluded of the many, a broad menu of things that they looked at was that the most impactful interventions would be expansion of treatment for OUD. And that's really what the focus of this workshop is on. So what I want to do is I want to go back to a study that was done in 1979 by Robert Newman, just as a reminder for those who may not have seen this before, in which they randomized people either to receive maintenance on methadone or to detoxify them. They randomized 100 people. They were inpatient for 2 weeks. They were all stabilized to 60 milligrams, which today would be considered kind of a moderate dose. Those who were assigned to stabilization and were for 32 weeks, at the end of 32 weeks, 76% of those people were still in treatment. Those who were tapered by 1 milligram per day over those 32 weeks, only 10% of those people were in treatment at the end of that time. At 3 years later, 56% of the people who were assigned to maintenance treatment were still in treatment, receiving a life-saving medication, while only one person, that's that little figure, was left in the program that was detoxifying. This was done when I was in high school, okay? I've been at this for a really long time. Subsequently, there have been studies like this that have been done for the very same purpose, both here and abroad, to try and impact policy. Policy is the place where we really need to make a difference. We have the evidence. We know it's unequivocal, but the policy is what needs to change. So this is a well-known local treatment facility that is in an unnamed state in the South. This is not a place that I would necessarily want my loved one to go to. It looks like an institution. The beds are numbered. This is some publicity about that facility. The heroin epidemic is plaguing this community, has led to unprecedented demand for services. About 95% of men and women in detox are addicted to heroin, but nearly all clients have been abusing multiple drugs. We have now just gotten $29 million new dollars to expand our detox beds. In this facility, patients spend 1 to 9 days detoxifying themselves with nothing other than mild pain relievers. This should be illegal. This is just plain discrimination. If someone wants to detoxify, I'm for that, even though I don't think it's the safest choice, but we have medications to make that humane. And if we're not using them, shame on us. And the reason that they say this is that this facility believes in full abstinence. I'm not sure how a facility can have a belief system, because I think it's actually just a building. But this is exactly the kind of thing that you hear over and over again when you actually go into the community and out of the academic setting. This is another option in case you're interested, and maybe you're from a more well-heeled family. I can tell you that you don't have to go to the beach in order to get better, and you don't have to live someplace away from your family for 12 months at the rate of $20,000 a month. I have met so many families who have had loved ones, children, adult children, who have been sent away to places for these long-term detox over and over again, only to have them come back and relapse. The families have spent the equivalent of what you'd spend to buy a house, to pay for a college education, and there's no guarantee for this treatment, and we have no evidence, as it was brought up yesterday, that it actually works. So if we don't change the way that we look at this framework, then nothing is going to stop what is happening in the community. So when we think about residential care, there are many residential and recovery housing type of programs that offer only detox and peer support. Some of them have few or no licensed health or mental health providers and are not actually what we would consider treatment facilities. So even under the treatment guidelines, they may not apply to some of these facilities because they're getting funding streams that are coming from criminal justice or housing authorities and actually have nothing to do with SAMHSA or another organization that might know something about evidence-based care. So here's my suggestion for change, and I can see my yellow lights on. Do not provide federal funds to programs that prohibit evidence-based care. Just stop. Put them on notice that this is what we're doing. Medication is the most effective treatment, and it should be promoted. And there's a lot of settings here for which it can be included. And because my time is running out, we can we can talk about those in a moment. If we want good care, we need to incentivize good care. Many reimbursement schemes inadvertently incentivize poor care. Even in Medicaid expansion states, reimbursement is often too low for private practitioners to accept it. And so, honestly, anybody who's providing good care for people that have opioid use disorder, it's complicated and it takes time. People come in, they have medical problems, they have other psychiatric problems, as you've heard about. That doesn't mean that you can take care of it with speed and volume, but that's the way that treatment is incentivized. And it really leads to this dehumanizing cattle call approach to treatment that we see both in methadone clinics and in some buprenorphine providers. So I think that we really need to reimburse sufficiently for integrated care. And this is just about the poor retention. We can come back and talk about this, but basically shows that very few people are staying in after 30 days. There's many reasons for that. We can discuss that on the panel. I do want to say that the new sustained release formulations of buprenorphine hold great promise, and I'm happy to talk about all of the evidence around those, but they will not do anything if we cannot get them to the patients. And some of our policies are just so backwards. So the implant was approved. The data were amazing. It works for 6 months. Patients stayed in, like the retention was incredible. But both the prescriber and the implanter needed to get a waiver. Why? Like, why? You know, and I understand that we're now changing that, but that type of restriction is just, it doesn't make any sense. And, you know, insurers can still require failure on something else before they give you the treatment that you want. And in this case, failure may mean death. We've got these closed distribution systems with specialty pharmacies that make timely access very challenging. Somebody else, Jody, brought up the price, which is also a problem. And they're coming out with this kind of buy and bill option, which is really not something that a small practice is going to do. And so these are just, I'll leave you with these data from Alex Wally showing that the need in blue for treatment, this is from a commercial database, continues to increase, and that our actual ability to deliver total medications for opioid use disorder in green, while it's growing very, very slowly, we are losing ground.
Thank you.